Morning, everyone. Thanks for joining us for the next session of Value in Health Week. My name's Sally Lewis. I'm the director of the Welsh Value in Health Centre, and I'm pleased to chair a really fantastic panel this morning. One of the strengths of value-based healthcare in Wales is the real momentum we have around a grassroots movement, really driving clinical work on the ground. And so we've got a fantastic panel of clinicians and managers this morning who are going to share some of their reflections and experiences on implementing value-based healthcare in Wales. So I'll introduce them as they speak. So first up today we have Mark Bowling. Hi, Mark. Mark is Assistant Director of Finance in Hywel Dda University Health Board, but has really been instrumental in Wales in driving forward costing methodology, particularly time-driven activity-based costing, and is due to finish his PhD on that topic, I think, any moment now, Mark, and really has been an early adopter of value-based healthcare right from the off in Wales. So, Mark, over to you first.
Thank you, Sally. Okay, so I've split my response into three parts. So firstly, from a personal perspective, what drew me as a finance professional to value-based health and care. Then in maintaining that finance perspective, what I feel a value approach offers us. And then concluding with where I think we are honestly in the journey at this point in time. So to begin with, I was looking for that different approach. I think we are blessed with the NHS and, but in common with universal healthcare systems worldwide, there are key challenges. And firstly, we all share a limitation in resources. And to make the best use, we need to understand how and where these resources are used and to what effect. And that's the important thing I feel for value. Key here also, and perhaps a quieter revelation, is that this isn't really about the money. Money is merely a common means and measure for the resources we're really interested in, being those that provide the healthcare. So the staff, the drugs, the meals, the facilities we work within, they're the true resources we're trying to look at. And secondly, at times, healthcare can appear to be a free good, and therefore waste does happen, even if that is unintentional. So the drugs that aren't taken, the appointments not attended, a treatment that doesn't achieve the desired effect, these can all waste these limited resources. So I think in the background of my NHS career, there's been some nagging and underpinning constraints. Initial roles supporting operational management teams were great and thoroughly enjoyable, providing that direct financial support. But I always felt this itch that in connecting the financial statements, I needed to understand what the money was being spent on more. And therefore, how do I describe that data and connect it to the financial resources? Which led me into costing world. Firstly, in leading a national programme for Wales to get the standard information up to scratch, and then from a strengthened base supporting the practical use of that data. And in fact, trying to embed that when I return to a health board environment. But even though then I'd managed that connection of cost with activities, there was a final piece of the jigsaw. And that was the question of, and to what effect do we use those resources? And that's where value-based healthcare, I feel, has that potential to be that unique answer to that question. So what I feel value now offers is, yes, financial ledgers have their place, and I'm not dismissing that, and traditional costing has its place, and unfortunately does suffer from a couple of limitations, in particularly in being connected to robust activity data. So if we don't have the activity data, as in a number of areas of healthcare, then we cannot make those connections. So we're not making visible that full spectrum of healthcare. And this is where the value approach comes in. And as Sally noted, the specific technique recommended for value-based healthcare is time-driven activity-based costing. Now, this is relatively simple to apply and can be applied to any activity that you can describe. And I've applied it in quite a number of activities over the time. So I think I'm safe in saying that there isn't anything I can't put a cost to. And in applying that, I've observed that it does shift the financial conversation. And this is through making the resource use and costs behind them visible in a clinically relevant way. We're describing the activities, not the inputs. And also this moves that focus from the accountability structure of a financial ledger that separates us into sectors of healthcare or specialties or teams and departments, and starts to look at that perspective of the condition and the pathway and moving us closer to that patient perspective. Through that clarity then, the accuracy of the underlying data, because I take, or we, in the costing world, take what clinicians and managers tell us and then convert that into measures of resource use. It becomes quite a transparent pathway document. But the honest reflection is this work does take time, so we need to apply this carefully. I will say that I don't believe value is a cure-all. Healthcare is complex, and I struggle to imagine any one system or one tool that could cut through all of the complexity. But I believe it has a very clear and a very helpful role, particularly as the originating authors described it as uniting the actors. Well, we could say the parties are our stakeholders, and that through the cost and resource use provides that common ground for a conversation that, if then done well, allows our transparent examination of what we commit to a pathway or treatment and what is achieved as a result, and not in some sterile experiment and back room, but in the real and complex world of NHS Wales. So to conclude, my thoughts on, are we there yet? And I think simply no, but I believe we've come a long way in the past decade. We're well on the journey to this. And to illustrate, we began with, well, what is it? How do we do it? And then got through, let's test this, let's embed it. And now we're at the point of let's share this more widely. And I believe, we are working nationally across Wales and sharing data, sharing the approach. From a finance perspective, I think there are still a couple of clear hurdles to negotiate. Governance is one of those. Now we have that statutory duty to break even and be clear in our obligation in protecting public resources. But within the accountability structures, we need value to shift that focus from the silos I was describing in teams into the conditions and pathways. And we will need strong leadership support to move the resources and help us shift resources both within and between pathways. I think there's also a challenge in describing, where throughout all of the offering of healthcare a resource is put to the best effect, because they are constrained. So where do we get that best use? And that might be outside of healthcare, in the prevention space, in the social care space. And also, as this grows, how do we adapt costing so we develop systems that can sit alongside PROMs and clinical data to maintain that transparency, but update as we move forward? And finally, I think there is that conundrum of protecting the space and time for us all to think about tomorrow versus our real pressing need to address today, which can, in honesty, feel very consuming. But optimistically, given the pressures the NHS is facing, how do we collectively face these challenges and constraints without considering value? Thanks, Sally.
Thanks, Mark. Whoa, there's lots in there from a financial perspective, and I've already got loads of questions, but I'll hold my fire until later. Please do put your questions in the chat, because we should have plenty of time for conversation once the panel have given their initial reflections. So now I want to turn to a clinical perspective from my long-time colleague, Dr. Gareth Roberts, who is a consultant nephrologist, clinical lead for value-based healthcare in the Anira and Bevan Health Board, and also clinical lead for the Renal Network. Gareth has been doing a lot of value-based healthcare work for a number of years now, including a healthy research agenda into PROMs. Gareth, can I turn to you next?
Yeah, thanks. I'm assuming you can hear me. My mic's okay. Yeah.
Yeah, all good.
Yeah, sorry, thanks. Yeah, similar to Mark, I'll define really I think it means, and how I got into it, I suppose, very simply, we haven't got much resource now, have we? You know, whether that's money, time, people. So we do need to use that resource wisely and spend it on stuff that actually makes a difference and stuff that works, is how I see it very simply. I started getting into this, like you said, many years ago, really. It started off when I was trying to get an expensive drug approved for one of our kidney patients, and then started reading about money and opportunity cost, and £1 here is £1 not spent there. And then we started doing some work in the kidney network on PROMs, and learning there's more to life than survival. It wasn't badged as value then, but we were linking it to cost. So it all ties in really to what we're trying to do now. And then in an Bevan, as you know, we've probably got about 30, 40 projects where we're trying to demonstrate value and improve patient outcomes. So yeah, obviously I'm a believer in the concept, which is why I'm here. I'm not going to pretend it's plain sailing, Sal, as you'll know yourself. There are hurdles and challenges which we may get on to discuss, but still a believer that we should be doing things with a value approach. I can't see how anyone's going to disagree with that, really, because what's the alternative? Do you know what I mean? No one's going to set up a waste-based healthcare approach, are they? Which is that's the alternative, isn't it? We spend money on stuff that really doesn't work. No one's going to advocate that. So I think the concept is fairly simple, and we should all be buying into it. It's a no-brainer. So it's great that Wales has embraced it formally, I think. Some reflections for me, really, on the benefits of having a focus on value locally and nationally, and having a national value and health group. I think it's been really useful to have a focus on the whole pathway of care. Traditionally, using the kidney network as an example, we would focus on the expensive downstream stuff, the expensive dialysis machine, the expensive drug, the new transplant antibody, etc. Whereas more and more now, where we've been given permission, because Wales is focusing on value, and people realise the importance of pathways now. So we're given permission to engage more in the prevention agenda of work with colleagues in primary care, to see, can we turn off the flow of people coming down and developing end-stage kidney disease? So I think having a value approach has really given us, anyway, in the kidney network, permission from WISC, from Welsh Government, and was pushing us now to get more involved, which is really refreshing, is what we've wanted to do for a while. So I think that's been really useful. And that pathway is not just the direct clinical healthcare pathway. We're having a focus on, the social care aspect, the importance of proper housing, the importance of people having financial support. So having that bigger picture view has been really useful for us, certainly in the kidney network, because if you don't sort out value in social care, you won't get value in healthcare. So it's been a bit of an eye-opener, and it's really expanded our horizons, I think, in the kidney network and in a lot of the projects in Gwent, focusing on that whole pathway where traditionally we look at pieces of the puzzle, wouldn't we? So that's been really useful. I think what's also been really useful, what we've been keen on for years in the kidney side, is metrics and data, because we're fairly data rich. But I think what having a push on value has done is put a real focus on measurement and, getting clinicians and clinical teams access to data in a way that is useful. And I know it's work ongoing, but certainly seeing a lot of progress in that. And, maybe I was guilty myself, really, of pushing PROMs maybe too far, to the point where people thought, well, you can't have value without PROMs. And I'm backtracking a bit now when I have discussions with teams. It doesn't have to be PROMs. You don't have to shoehorn PROMs into every single business case. There's certainly a role for PROMs, but it's just have some metric that you think demonstrates value. And it's not always PROMs. It may be PREMs. It may be process. Sometimes process is good enough. We've got projects where specialist nurses are reducing hypoglycemic attacks in hospital. You don't need a hypoglycemia PROM. Just showing that you've reduced hypos is good enough, I think, to demonstrate its good value. Or in diabetes, just demonstrating you're getting people onto proven therapies, which have been published and NICE approved and will reduce heart failure, will reduce the number of people going on dialysis. I think a process measure there is good enough. So it's just enable those discussions about, the importance of measuring, but picking the right measurements, whether that's PREMs, PROMs, cost, process measures, sometimes all of the above. But you don't necessarily need to shoot on all of them either. And I think, having those discussions has been really useful. And I think that's where the value-based healthcare teams have a real role. I think that's where the expertise is, enabling people to access, IT platforms, know what's out there, know what can be done remotely, help with a bit of resource to analyze data. Because I think sometimes the terminology has been confusing for people, where they almost see value as a discrete team. You know, oh, we've got a difficult problem, we can't get people off the board, give it to value. You know, and that's not how it works, is it? You know, it's not a discrete team working in isolation in the health board. It's not a value team. You know, that's been confusing, I think, for people. What we want, obviously, is for everyone to think in a kind of value-based approach to their day-to-day lives. All of us being paid, you know, by the NHS, we should be thinking, am I actually making a difference? You know, I've worked hard this week. Did what I did make a difference to actual patient care? And if far too often you think, well, actually, that didn't make any difference, I wasted, that you need to have a think, am I doing the right thing here? I mean, that's not just clinicians in clinic or people chopping off legs in theatre, that's everyone. You know, my secretary answering calls and writing letters and dealing with anxious patients every day is making a difference to outcomes. You know, people working in finance can make a big difference to outcome, the directorate manager. So we should all of us be thinking in that way. It's not a discrete value-based healthcare team doing value on behalf of the health board. So we haven't quite got there, I don't think, with that. And maybe the terminology hasn't helped with that, but we just, there's a few hearts and minds to be won over with that still, I think, but we're getting there. And the other advantage, like Mark has discussed, is, you know, the having wider costing discussions. Certainly years ago when I started, it was very hard to get honest discussions between the accountant, the finance partner, and the clinical teams. Do you know what I mean? It was like two reluctant pandas in a zoo that had to be forced together by the zookeeper sometimes, but didn't really want to get together. I think having this approach, linking costs and outcomes, has given people almost permission to have those discussions. I get it, you know, the concerns, if you give clinicians access to the safe, they'll just take it all and you'll get a tragedy of the commons. But we haven't seen that with the Kidney Network, quite the opposite. When clinicians trust what they're being told, you know, they trust the cost data, they see where all the money's going, then the conversations are quite honest then. And actually they see where we have had areas where people will say, actually, you need this more than our service right now, but maybe next time we'll do this. So I think that's been really useful to have a focus on value, to bring clinicians and accountants together and to build a bit of trust, both sides. So have more honest conversations. You know, there's nothing more frustrating than someone saying, don't worry about that, it's complicated, you don't need to worry about the money, we'll deal with that. You know, that creates a lot of mistrust then. So I think having a value approach and a focus on outcomes and costs together has been really useful in that space. So yeah, I'm sure we'll get onto some questions on challenges and hurdles, etc. But clearly still a believer, and I hope we can continue, because like I said, you know, what's the alternative to having a value approach? There's no alternative, I don't think, so it's the only show in town. There we go.
I would agree, but then I would. Thanks, Gareth. And you've alluded to a lot of elements of cultural shift there. And we've got some nice questions coming through in the chat. Please do put your questions in. I know one or two of you have had a few problems with sound. Doesn't seem to be a universal problem. So I know we've got Gareth and Brooke on the call as well. So we'll try and investigate why that might be, but it does sound like some kind of device setting issue.
Am I allowed to come back in, or am I kicked out now? I did want to mention that the other key point is what having a focus on outcomes and stuff has done is enable areas who wouldn't previously have been funded to get some funding. And I think that's really important, you know, because previously we would have found areas being funded according to the length of their waiting list and almost perverse incentives to get money. Whereas, you know, some of the money that's been put in from the centrally now for value projects, we're seeing areas that would have died off now having a bit of life support and really thriving, making a huge difference. And those services would just have fallen apart without this kind of mindset that is new, you know, to focus on, well, if you can demonstrate good outcomes to make a difference, we will support you and we'll support you with some funding. So we've got some really good examples, both nationally and in Gwent now, of services which would have withered on the vine without a bit of cash, getting a small amount of money and now just thriving. You know, and the enthusiasm in those teams is there to be seen, you know, when there is no enthusiasm at the moment, is there really? So I just think diverting money into stuff that works just gives people a little bit of hope as well, you know, that you can still make a difference, because there are still people out there enthusiastic. There are many people who are not enthusiastic, and I get the reasons why, but there are pockets of people still doing some really good work and enthusiastic. So having that value money has enabled some of these areas to really fly. And my experience, when you give good people some money, they tend to do good things with it. So I just wanted to make that point. Thanks for letting me back in.
Yeah, really important point, Gareth, and maybe we can dig into some of those examples in the discussion, because I would agree that the data-driven approach in Wales has started to help us meet unmet need and tackle some of the inequities that we've seen in resource allocation. Small steps, but I agree that's been a little bit of progress there. So now, Sophia, new to the value-based healthcare world, or relatively new, Sophia is now the programme lead for value-based healthcare in Cardiff and Vale University Health Board. Sophia has 10 years of operational management experience, but is, I believe, a cardiac physiologist by background, which I didn't know. So that's good to know, Sophia. Can you give us your reflections of your journey, really, over the last year or two?
Yep, so I've got some slides to share. So I hope you can see the screen.
We can see and hear you perfectly.
Fab. So warning, cuteness overload coming. But when I was asked this question, what it means to me, I immediately thought about my favourite person in the whole world, which is my little boy, Oliver. So he's 19 months and he's a bundle of joy, but also a pain in my backside, because he is a joy to be around, handful, toddler, all the things that you hear about toddlers, he's that. But he had a rocky start. So when he was born, he had low blood sugar. So he was on ITU for 10 days. And I was next door pulling my hair out. And then once he got out of there, he was struggling to gain weight. He was really small. And he was struggling to do the things that other babies of his age didn't know why. Everyone came to visit and said he was okay. Maybe we try this, try that, all that stuff. And then something wasn't quite right. We went into the doctors and he was diagnosed with bronchiolitis, rushed into ITU again, had the oxygen and all sorts of things. And then we'd found out that he had a heart murmur and a giant hole in his heart. So we went through that whole process of cardiology tests and being listed for open heart surgery. And then I became an at-home nurse, which I don't know, I'm very good at that, but I had to give medication all the time, feeding every 2 to 3 hours through a NG tube, which you can see in one of the pictures, and waiting for that waiting list to come down for him to go to surgery. And that was quite a challenging time, and it felt quite isolated because it was, well, you just have to wait, and here's the medication, and we'll see you when your time comes up. So we finally got surgery when he was about 7 months old. Didn't have an ITU bed, but we went in anyway. And then thankfully there was an ITU bed. So the anaesthetist rushed us down, walked around Bristol for hours and hours and hours to pass the time. And then he had it done and it was amazing. And he's fantastic. He runs around and plays with all the kids and jumps on everything, climbs up and down the walls. So it's a great outcome for him. But when I was thinking about value, we were talking a lot in our consultations about the surgery and the outcomes of the surgery, success and risks and things like that. But what I really wanted to know, what really mattered to me was, can he roll around like the other babies of his age when we have this done? Can he run away from me when I want to change his nappy when we have this done? Can he play football if he wants to when he's older, or wrestling if he wants to when he's older, or, you know, all of these things? And that conversation, it wasn't there. And that's what really mattered. So how do I now in my role help facilitate that, or make people have the space to think about that, and how, because I'm sure everybody wants to have those conversations. It's how do we enable them to have those conversations and do something about them. But then there was also that part about, and I still probably don't think too much about it, but me and my husband, and on the night of the surgery, we slept in the car because we had nowhere to sleep. And thank God I bought a car with heated seats because it was freezing. It was this time of year last year. And then with a lack of sleep, had to look after him on the ward the next day. And with all the beeps and the buzzes and everything that had to come along post-surgery. And it's not just him in that scenario. It was, what about the family, carers, the support network? What to enable him to succeed in his health and outcomes, there's other people that need to facilitate that. And how do we make sure there's that wraparound care for everyone? And then post-surgery, I mean, the care was fantastic. Everybody was amazing, but you could really see the constraints that we're under within the NHS and where the bits get left out across the pathway or that care package around people. So that I thought about him when we were thinking about what matters to me in value. And then that's him yesterday dressed up as a reindeer. I thought that was quite fun. And then I also thought about my nan. So my nan passed away many years ago now with cancer, and she was a force of nature. She did everything independently and she did everything. She was like the chair of the block of flats they lived in, and she did every charity thing. She was awesome. But towards the end of her life, she didn't want the fuss. She didn't want to go to hospital. She didn't want to die in hospital. She didn't want to have to take all these medications that made her feel sicker, all this stuff. But I think what we were doing, we're trying to give her the best quality care we could give her as a health service, not necessarily thinking about what she actually wanted at the end of her life. And we were really fortunate to be able to go to a hospice at the end, and she had fantastic care and experience there towards the end. But how do we make sure that we capture what people want and then try and help them get that? And I know there's resource constraints everywhere, but do we ask the questions? Do we think about what people actually want? And then my grandpa on the screen, he'd struggle to look after her when she refused to eat the food that she had to eat or didn't want to take the meds she had to take. So then he was pulling his hair out. And he's an elderly gentleman looking after an elderly sick woman. So what is that wraparound care? It's, how can we support people get the outcomes they want, and who is supporting them to get the outcomes they want? It's not just the health professionals. And then I also thought about my career as a clinical member of staff, and these are some of my team members when I was working clinically. And I worked a lot with cardiac devices and programming for patients with heart failure devices or cardiac defibrillators and pacemakers. And you get a gold standard way of programming a device or out of the box settings. And then you program what the evidence base tells you. Great, you should be fine. But when the patient comes back and says, I can't walk for the bus to go and meet June in the coffee shop on a Friday, you have to go beyond those gold standard settings and think, well, what is it in this device that I can help you walk to the bus so you can go and see June? And you make those personalized tweaks, and you have to ask those questions. You have to say, what do you want to achieve in the next month? Do you want to go running like you did before? We had patients of all ages with these devices, and some were avid runners, and then when you put the device in, they can't run. They feel that brick wall when they're running, and they can't do what they used to do. So you've got to tweak their programming. Otherwise, if you don't ask the questions and find out what people actually need and want, they would have that standard setting and maybe for the rest of their lives be struggling to do what they want to do. So it's really about putting that person in the center, having that person-centered approach and trying to help them achieve their outcomes. So that's really what I was thinking about. And then in my role now as program manager for Cardiff and Vale with my team, it's really facilitating teams, individuals, boards to be able to ask those questions, find out from patients, use tools, techniques to be able to get that information. And then how can we help optimize that pathway, optimize what we're offering, look at where we're resourcing, what we need to maybe increase our resources in to be able to deliver the best care we can.
Thank you so much for that, Sophia, for sharing those very personal stories. And I think has highlighted such an important point, that this is all about what matters to people and how do we elicit people's goals and preferences for care and really attend to the small things, what really matters to people. And to remind ourselves that no matter how good our standardized evidence-based medicine and pathways are, that doesn't really help us with that, does it? So there is that real human element there. And I just want to share with you a comment from Raquel in the chat, because it's so lovely. She says, I would just like to point out the bravery of Sophia and Oliver and send you a huge hug all the way from Berlin. Your story is absolutely why we all need to keep pushing through the value agenda. Bravo for sharing this story, and congratulations on your toddler warrior. So I thought that was a lovely comment. Thank you, Raquel. So, some really important points in there, and wonderful that is you know, driving you to make sure that starts to happen more often across your health board and across Wales. So next I want to come to Claire Dunstan, Dr. Claire Dunstan, who is a consultant anaesthetist and also now the clinical lead for value-based healthcare in Cardiff and Vale University Health Board, has quite a long history of improvement and is also a Bevan exemplar. So Claire, can I come to you next?
Yeah, absolutely, Sally. I'm just going to share. I've got a slide deck to share as well, so I'm hoping that you can see it. Okay, can you see that, Sally?
Not yet, slight delay, but I think it's coming. It's coming.
Taking a while.
It's on its way. We can see a slide, but it doesn't have any writing on it.
Okay. No, it doesn't have any writing on it my end either. I'll carry on talking.
If you just hit your space bar, Claire, it should bring up your titles.
Oh, here we go. Okay, so
yeah.
So yeah, when I was asked what I thought, what value meant to me, I tried to think of it in sort of a larger perspective about how healthcare always evolves and how it's always continuing to evolve, and it will evolve with us or without us, really. And so if we think about it historically, the first revolution was empiricism, and how we thought about healthcare changed there. We had a second revolution when some hard science came into play, and we started improving healthcare using innovations such as, you know, joint replacement, CT scanners. And I think we're currently coming towards the third revolution of healthcare. And this is how I feel and see value being really useful, is that citizens have a lot more knowledge than they ever have done, and they are all using their smartphone. So if we look at the way that we analyse healthcare, Cochrane in the 70s made sure that we were effective and efficient. In the 90s, NICE used that then to standardise our guidelines. In the 2000s, we analysed ourselves against those NICE guidelines. And now we are looking more at the value perspective and trying to put what I feel is all these things together as one. So I know nobody's put up the value equation yet, so I'm going to put it up. But what does it mean to me? It means about doing the right thing, using common sense decisions, but also, if we need to, disrupting the healthcare system and asking why we're doing things that we've always done. Is it always the right thing to continue doing? So on that back of that, I'm just going to give an exact practical example really of how I've gone about doing value and what it means to me at the current time, because it always changes, I think. So this is an example of what we've done in Cardiff and Vale. So this is one of our latest projects. We've got about 15 or so projects in the surgical board ongoing at the moment. And what it means to me is enabling the clinicians. So Drazen's one of our very new MaxFax consultants, and he wants to use sentinel lymph node biopsy for oral cancer. So he's thought of a really good idea. It's really important for patients. They stay less time in hospital. They have less of an operation. They have better shoulder mobility after the operation. But how does he go about planning that? So for me, value is helping people plan what they're thinking. So a lot of clinicians are very poor, I know I can say that, at planning projects. So I've got a few slides which I use and we discuss and understand what's in scope, out of scope, and what we can deliver. The other thing that I hope that clinicians are doing is planning and using timelines and evaluating things as they go. We've discussed risks and issues that we have. So there's always risks. And with this particular project, there were a couple of risks with radioactive materials, making sure that the patients, once they were injected, have a list the very next day, well, within 12 to 16 hours. So it's about getting the clinicians to think about, yes, you've had a great idea, but how are you actually going to plan that? What particular subset of patients are you going to do it to? How are you going to do it? And how are you going to discuss with other clinicians how it's going to work? Particularly with this example, we had an issue with a barrier, or an issue, whatever you want to say, with the pathology department. So it was about understanding how much cost they would have with their slicing of the lymph nodes. So that then meant that actually this project was a non-starter because the costs of the pathology outweighed the reduction in time in ITU. So I think if clinicians understand why that something isn't financially viable or environmentally viable or isn't useful for patients, then they can understand actually why these projects aren't doing. So I'm quite keen that we move towards this rather than a business case based healthcare service. So we're looking at our benefits at the end of it, and what is really important for me within our area of usage is that we then invest that. So the money is never, it's all, I don't know whether Mark will agree with me, but the money is always reinvested in something else in healthcare. There's never any free money. And so what are we reinvesting in it? So for this example, what we're going to reinvest it in is long waiters. So it's just thinking about the whole process for the clinician. And this is a sort of a summary slide I use. And what it means to me is having a really good understanding of what we're doing and why we're doing value, whether it's, if you see in the bottom left corner, it's the financial value, whether it's the environmental value, social value, what are we doing, why we're doing it. So sort of my role in value is to help clinicians understand what it is in a very basic way, but how they can use it to drive projects that are common sense. So I think I'll stop there.
Thank you, Claire. That's incredibly helpful, and I think really highlights Gareth's earlier point, I guess, in that there are many ways to improve value. So some will be about tailoring care to the individual, very much in the way that Sophia was describing. Some will be about how we allocate resources better. But the important thing is you've got to have a coordinated approach to doing this, otherwise there's potentially a bit of chaos ensuing, and I can certainly relate to that. So I'm sure there'll be lots of questions on that.
I think the important thing is that we have a really good relationship with finance, so that we understand. So I do have a really good financial partner that helps with all of this, and if they're not on board from the beginning, then it is really difficult to do any pathway projects, any exemplar work. It's got to be a team effort.
Yeah, I completely agree. Thank you for that. And now we're really lucky because Idris has been able to join us. Thank you so much, Idris. I know you're straight out of clinic. Idris Baker is a consultant in palliative care medicine and a long-time collaborator with the Welsh Value in Health Centre. Idris is also the National Clinical Lead for Palliative and End-of-Life Care in Wales. So Idris, thank you so much. I don't know if you have slides. I know you've rushed in, so please do share your slides if you have them, and I'll hand over to you.
Yeah, thanks, Sally. And I'm sorry not to have been here for the whole of the panel discussion, but I've really enjoyed the last 10 minutes or so that I've heard. I don't have any slides. I'm afraid you're just going to have to well, you can probably find something better to look at than me, but maybe we can just share some thoughts about what we've been up to on our sometimes slow and painful journey on value-based healthcare, but I think a fruitful one we're finding. I work as a mainly community-facing adult palliative medicine consultant in Swansea Bay, which really means they pay me to drive around the Gower Peninsula, largely seeing people at home. And so I've spent quite a lot of my working life trying to do palliative medicine for what in my case is adult patients, but of course I've got colleagues who see children with other kinds of conditions, and I see mainly people with progressive life-shortening illnesses. And I grew up in this culture. I mean, we all know a bit about the culture of palliative care. We're absolutely sure that it works, right? We're absolutely sure that it helps, right? We're kind of saintly, aren't we? There's no room for questioning that palliative care really helps people. And of course it does, and we've got over the last couple of decades a growing evidence base. I was really grateful for Claire's scholarly analysis of how the thinking on this has evolved. You know, we've been on that journey of having growing evidence that a lot of the things we do can work, that they can help people, they can improve symptoms, that they don't kill people. I mean, it used to be thought 20, 30 years ago that, okay, you can improve people's symptoms, but it's going to shorten their lives. And we've got the increasingly compelling evidence that it doesn't. And we've got decent processes, particularly within specialist palliative care services, for implementing that evidence, for using it. But how do we know if it's actually helping? And again, I'm grateful for the little bits I've heard of the presentations today. How do we know if we're doing it for or with the right people? Specialist palliative care teams see in total, we know in Wales, about a third of the people with progressive life-shortening illnesses at some point in that last phase of their life. 2/3 we don't. And of those we do, the median interval in the most recent cohort we've looked at is just over a month between referral and death. Well, that's been a lot of palliative and end-of-life care been happening without specialists being involved. And even when we are involved, I might go and see someone at home, but I'm not probably going to be the person who's out at 2 o'clock in the morning giving a subcutaneous dose of PRN morphine for their pain. That's going to be a district nurse. Most of the work we know is actually being done by people who are not palliative care specialists, and being done, I think, very well. In fact, I've seen it. I'm not here mainly to tell a personal story. I was grateful to hear part of Sophia's, but you know, I've experienced in my own family very good generalist palliative care being done on acute hospital wards, you know, those places that we think are not promising for doing good palliative care. Well, I've got to tell you, they can do it really well. So we know there's a lot of that being done in all kinds of settings, and really our journey in value-based palliative and end-of-life care has been an attempt to answer these questions. Are we getting the right outcomes, the right experience for this person at this time? Not just in the context of a specialist palliative care team, but for anybody who's needing some form of palliative and end-of-life care. The thing about, I guess, what we do is that a lot of the usual goals of healthcare are increasingly out of reach for the people I've got the privilege of seeing as patients. Long life and good health, okay? Those are things which are galloping away from most of the people I get to see. They're normally quite valuable goals to pursue, but we have to have frank conversations about not being able to achieve them. And what we find is that as those things become unattainable increasingly, so the subjective, the person-centered, the stuff that's about goals and preferences and fears, the things we most want to pursue in that phase of our lives, the things we most need to avoid in that phase of our lives, that becomes more important and in fact becomes everything, because it's all you can pursue. And so that's where the value can be located. Now, on a practical level, a lot of this, and this is work in progress for us, I'm not going to claim that we've achieved this, but a lot of this is about measuring and understanding the costs of what's done, and that's surprisingly difficult. And then putting in place the systematic measurement of the outcomes and experience for patients and for those close to them who may be involved in caring roles. It's doing both of those systematically and not just doing it for the little bit that's being done by specialist services, but being done for the whole experience. The costs, I said, is astonishingly difficult, but just an interesting little figure. Well, these are not even validated figures yet, so I won't give you figures, but a ballpark. Do you know the NHS in Wales spends between 4 and 5% of its budget putting people who turn out to be in the last 12 months of their life into the back of ambulances and delivering them to the front doors of hospitals and then keeping there for a bit? 4 to 5% of the whole spend of NHS Wales is on that. I mean, it's a substantial 9-figure sum. Now, some of that is adding a lot of value. Don't you dare conclude that people who live in nursing homes who may be in the last year of their life shouldn't ever be put in an ambulance if they fall out of bed and break their hip, and you know that person needs to go to hospital and needs to go to hospital now. Don't be part of a system that says, well, no, that's not helpful. That's desperately important. But we also know, and at the moment we only know it anecdotally because we've lacked the data systematically to demonstrate it, but we know that a lot of those episodes, a lot of those encounters are not actually adding the greatest value to that person's life at that stage in their life, because that thing isn't helping in the way that it would have helped 2 years ago. And so we're trying really hard to bring some focus to that kind of question. How can we actually take out some of those interventions which we know are adding no value, or maybe negative value, if you'll allow that as a concept, and find better things to do instead? How can we, it's really just that application in that context of the question of how we can know we're actually getting the best outputs we can for the quite substantial work that goes into the care of people in that phase in their life. It's very much work in progress for us as a program team, but that's what we're seeking to do. I'll stop there.
Thanks, Idris. And gosh, there's some astonishing insights there, and you highlight also the complexity, excuse me, of the situation. But it just goes to show that not all of our resources are allocated or spent in the best possible way to meet everybody's needs, isn't it? And the devil, I suppose, is in the detail around how we start to tackle some of that. So really important work going on there. So we've got time for questions now, and I've got lots of really good questions coming through. So Mark, question first of all from Raquel. Raquel, I know, is a French GP now living in Berlin, who is a long-time friend of Value in Health in Wales. So good morning, Raquel. Thank you for joining us. Raquel wants to know, have we, you mentioned you can cost just about anything, Mark. If it moves, cost it. Raquel's interested to know, could you apply costing methodology to assess the value of current approaches to medical education versus a reform to the curriculum that gave a more value-based approach to that education? So I guess we'd have to look at the outcomes of the education as well to do that. But what are your thoughts on that?
Gosh, me and my big mouth. Right. Short answer is yes, we could, but it's being very clear on the, as you're suggesting, Sally, the question we're attempting to answer. And if it is the additional quality of, you know, medics then approaching their role in their life and career with value in mind, then that's quite a longitudinal study. It could be done, but I think that's quite challenging. At a simple level, you know, we've contrasted medical education in orthopedics, say. So, you know, in an active pathway, what are the additional costs of those training compared to those doing it full time? So I think it's being clear on what we're trying to get out of that one would be my suggestion, but not impossible.
Thank you, Mark. And the next question is from Sarah Bradbury. Thank you, Sarah. How do we access funding for value initiatives within individual services? Is it national or via the local Value in Health teams? So in answering this, I would say your local teams are a really good resource here, and I'd like to bring in Sophia and Claire on that one, but I'd also like to bring Gareth in terms of how some of that value-based healthcare allocation fund has been spent very specifically. I know you mentioned earlier some big impacts from small amounts of money, Gareth. So if we can come to Sophia, Claire, and then Gareth for some reflections on that.
Yeah, so money is tight everywhere. And I think what's been useful in Cardiff and Vale as a value team is trying to understand what's going around the place and where ideas, projects, initiatives, where they fit into the work streams established in the organisation, and then also if they need something a little bit more specific potentially from the value programme, and really getting that conversation with the key people. And there's pots of money in all sorts of places, and we've been talking about it recently in the last couple of weeks. There's charities, there's companies, there's partnerships, there's internal, all sorts of things. And I think what's good from my perspective as a value program manager and with my team is we talk to so many people, get that golden thread of what everyone's trying to achieve, and try and direct the pots that might be available or the people that might be able to help push things through with whatever resource that they have.
Thanks, Sophia. Claire, would you like to add?
Yeah, because we started in the surgical board in Cardiff with nothing So we had no money, no investment. And so it does show you that things are possible. So our very first project was transnasal esophagoscopy. And that is a pathway reduction project, but also an innovation project. And we went through the whole process of costing, environment, et cetera, et cetera. And if you've got the right people in the room, and our costings on that, I think came out as an investment of 60 or 70,000 to save £400,000 recurrently every year. So once you've gone through the whole process of value, which does take some time, but you do get quicker at it, I'll say that. Yeah, then you can prove. So then when you start, you've got to have people that are on the same page as you, especially in finance. And I was really lucky that my finance partner was on the same page as me. Plan it, make sure you get the right data, and yeah, keep nagging as you go through those projects. But that's how we start our projects, is with nothing, is proving that actually what we're asking of the health board is very sensible and cost effective. So why keep doing, like Sally always says, I'll steal your line, Sally, what is the do nothing option? Carry on spending that extra money? That's not the option, is it? So yeah, that's what I would say. If you've got no money, really plan your projects and then speak to the right people.
Yeah, so highlighting to the organisation the cost of not doing the thing, that often lands well with finance, doesn't it, Mark? Gareth, can I come to you for your perspective?
Yeah, money in general, really. If I start with money in general, if we go back 5 years, Sally, it was a bit easier, I think, to get small amounts of money to run projects from health boards. We're in a very different climate now, where it is exceptionally difficult to get money from business cases to the health board, isn't it? You know, it's really difficult. Now we can all talk about stop doing expensive stuff upstream, invest it downstream. Right now, very often any saving is just sucked back into the deficit. So it's really difficult at the moment to get money from business cases to the health board, which is why I was alluding to when money became available for value-based healthcare projects, that was really useful. So there were two pockets of money, for those of you who may not know. There was a national pot, which you could bid for national projects. So from the Kidney Network, we put a bid in for that because we'd already done the work to show home therapies from a value-based perspective is the best therapy. Transplants from a value-based perspective is the best therapy. So we put a bid in to maximise patient access to those therapies, which we already knew were proven to be the most value-based. And those projects are going really well. It's not a one-size-fits-all. Each health board had to then tell us how they're going to use the money to make sure locally they improved access to those services. And it's slightly different in different pockets of Wales. Some may need a transplant nurse, some may need prehab, etc. So that was a national pot. And then each health board were then given an allocation to spend on value, weren't they? And as local value-based healthcare teams who had some say in, you know, how to spend that, we have invested some money in the diabetes inpatient service, the DICE team, which are absolutely flying now, and the enthusiasm and the work they're doing is great. We've got community projects about prescribing drugs that we know work and prevents complications. You know, we previously had the alcohol liaison service, which is flying now across Wales, and none of those would have taken off really without that central investment. I would say the timelines to put a bid in were very tight. You know, but it's great there was money there, but the timelines, what we'd have loved to have done is open up every specialty, send us a business case and we'll stratify them. The times were so tight, it had to be something that was almost good to go off the shelf really for that money. So what I would suggest to anyone with a project is make sure your project is written up and ready to go off the shelf, because money sometimes just comes and you have to have it there ready, and you know the costs all added up. Have it so it's off the shelf, you can just put it in, because sometimes just money appears. Now there's also, we've been a bit more creative with finding money, certainly from the kidney side. You know, we've managed to collaborate with charities to get some money. We're collaborating with industry to get money. That's, you know, we've got some pharma industry funded projects around, you know, different ways of working. It's not just pharmaceutical industry. We've collaborated with utility companies under their obligation to help vulnerable patients. They've got money. You know, so you need to think outside of purely a business case to the health board. I think there are other ways of getting money, I would say. Maybe your local value-based healthcare teams can help with that. But it's first and foremost having the business case good and ready to go, knowing what you need and how it's going to demonstrate outcomes. But there are different avenues to explore for money, even if it's not the health board or even the Value and Health Centre, I think.
That's great advice, Gareth. And for those of you on the call who don't know, Gareth is very good at rooting out bits of money here, there, and everywhere. So be creative, have a plan ready to go, and if in doubt, go and ask Gareth. No, I'm just joking. Couple more questions. We've got 5 minutes left. I want to explore how value-based healthcare helps us tackle unmet need, because as Gareth has suggested, we've really started to direct resources towards areas that have really struggled. And a lot of value-based healthcare is about doing the basics really well. And one of the basics, Idris, I'm thinking about is the timely identification of people with palliative care needs. And I know that you're doing a lot in that space. Could you talk a little bit about that, please?
Yeah, I'll try to. You took the words out of my mouth, Sally. Timely identification is key because, of course, then once you've identified people who have or are developing needs for, well, any particular thing, but in my case, it's a need for a palliative approach to their care, then we could, in principle, start to look at their outcomes and experience and actually demonstrate the gaps in what's provided to them at the moment. So we know something about how the need for palliative care can be identified. We know something in that there are some, disease-specific indicators. Of course, a lot of the early work on this was done in the context of cancer, where it's been fairly well understood for a long time. But cancer, of course, causes a minority of palliative care need, about a third of it, probably. Another third of it, although it might be falling over the long term if some of the good preventative work goes on, another third of it being caused by organ failures. And another third of it, and this is the bit that's clearly growing and it's unsurprising, is associated with dementia and frailty as a main diagnosis. The other important caveat, of course, a lot of people increasingly living with more than one serious illness who need palliative care. So that makes it a little bit harder over time to define it in terms of individual illnesses, but there are other non-disease specific ways that we can begin to characterize what that need might be. And the key thing is having a clinical workforce at the coalface who are thinking in terms of that being a possibility and are seeking to anticipate it. So whoever has contact with that patient, asking themselves that question. Now, it's sometimes been framed as a surprise question in terms of the lifespan we think might be needed. Would I be surprised if this person were to die in the next 12 months, for instance? Increasingly, we're trying to move more towards thinking less about time, because time isn't actually what defines you as having that need, and more about, well, what your needs are. Are the needs of this person needs that I can turn around by improving their health and getting them back to being on track for long life and good health? Or are they in fact needs for support and symptom control in the context of an illness that I expect is going to continue to get worse? Because that's palliative care need. If we have a workforce of whoever is seeing patients, and so this means in primary care, it means in hospitals, it means at the front door of the hospital, it means ambulance crews, it means whoever might encounter them, and they're commonly encountered in all those settings, who are thinking in terms of that being a possibility, who are aware of the fairly basic evidence about how you can go about characterizing that need, and who communicate with each other. And if, by the way, we put systems in place that make it possible for them to, so that the chest physician who sees someone in his respiratory clinic and knows that actually this person, now we're expecting deterioration over time, just makes sure that he lets the GP know that. And there are fairly straightforward ways of doing that, or they're not. Letters exist, so it's not impossible to communicate some of that information, but we might be able to get smarter using better digital systems over time. How we share that perception, starting point. What's the point of doing it? Because people will say to you, well, what's the point of timely identification? That doesn't achieve anything. Well, it doesn't, but it allows you to do the next things. What we're wanting to put in place is a system that will systematically capture the outcomes and the experience. And we've got a core outcome set agreed, and we've got tools that can measure it. The outcomes and the experience of everybody for whom that palliative need has been identified from the start. And so that we'll have a dashboard that lights up where those needs are being met, great, and where they're not being met, and then we can focus.
Thank you, Idris. Really important work going on there. And unfortunately, we've timed out now, which is such a shame, because I think this conversation could probably run and run. There are some additional questions in the chat, so we will commit to providing responses to those questions for you. I'm sorry we didn't get to them during the session today. So it just remains for me to thank our wonderful panel this morning, and thank you all for joining with us and sticking with us for the last hour. Thanks all. Bye bye.